Hello, my name is Dr. Angela Yuan. I'm a urogynecology fellow at the Cleveland Clinic. Today, I'll be presenting my research presentation entitled Perioperative Adverse Events After Vaginal Prolapse Repair with Uterine Preservation versus Concurrent Hysterectomy. I'd like to thank my co-authors, Drs. Chang and Ferrando. These are our disclosures. There is a growing interest among surgeons and patients in uterine preservation compared to hysterectomy at the time of apical prolapse repair. There are now level 1 data demonstrating similar medium-term efficacy of uterine preservation, also referred to as hysteropexy, versus vaginal hysterectomy with prolapse repair. Although a recent systematic review demonstrated that hysteropexy was associated with a shorter operative duration and less blood loss, there are few studies that offer a direct comparison of adverse events between these types of surgeries or between hysteropexy types. Thus, the aim of our study was to compare the incidence of adverse events between vaginal native tissue prolapse repair with uterine preservation versus hysterectomy. Our secondary objective was to compare the incidence of adverse events between sacrospinous and uterosacral ligament hysteropexy. We hypothesized that patients who underwent hysteropexy would have a lower incidence of adverse events compared to those who underwent hysterectomy. This was a retrospective, matched cohort study of patients with uterovaginal prolapse who had their surgeries between 2012 to 2019. All hysteropexy patients were matched to concurrent hysterectomy patients at a 1:2 ratio by surgeon, surgery year, and age. The electronic medical record was queried for demographic and all perioperative data up to 6 weeks postoperatively. Adverse events were defined a priori, and Clavian-Dindo grading was used. Hysteropexy patients were identified with CPT codes for extraperitoneal and intraperitoneal colpopexy, and each chart was reviewed to ensure that hysteropexy was indeed performed. Matching patients in the hysterectomy cohort were identified with these same codes, plus those for vaginal hysterectomy. We excluded patients who underwent mesh-augmented or abdominal prolapse repair procedures, as well as those who had concomitant procedures for gynecologic cancer. A total of 390 patients were included in this study. 130 patients underwent hysteropexy, and these were matched to 260 patients who underwent prolapse repair with concurrent hysterectomy, with the specific native tissue approaches as indicated here. There were no significant differences in patient demographic characteristics. The only statistically significant difference between cohorts was the incidence of concurrent non-prolapse procedures, such as salpingectomy and oophorectomy, which were more common in the hysterectomy group. The overall incidence of perioperative adverse events was significantly lower in the hysteropexy cohort than in the hysterectomy group. When excluding UTIs, the incidence was 2.8% compared to 11%. Of note, there were no differences in the incidence of severe Dindo grade 3 or higher complications. When we examined the intraoperative data, operative time was significantly shorter in the hysteropexy cohort with a median difference of 53 minutes. Estimated blood loss was also significantly less, with median difference being 75 milliliters. The incidence of intraoperative complications was significantly higher in the hysterectomy cohort. Specifically, the incidence of intraoperative ureteral kinking was 5% compared to 0% in the hysteropexy patients. There was also a higher incidence of having an estimated blood loss greater than or equal to 300 milliliters. There were no statistically significant differences in the incidence of these postoperative complications. The hysterectomy cohort had a higher incidence of prolonged hospital stay greater than 1 day after surgery. However, there were no differences in the incidence of reoperation, readmission, or ICU admission. To control for confounders, multiple logistic regression was performed. Concurrent hysterectomy with colpopexy remained a significant predictor for experiencing any perioperative adverse event, even after controlling for age, ASA class, estimated blood loss, operative time, and concurrent non-prolapse procedures, with an adjusted odds ratio of 4.03. Lastly, we examined the incidence of adverse events by vaginal hysteropexy types and found no differences in the incidence of adverse events. The only difference seen was in the operative duration, which was longer with the uterosacral approach. Limitations of this study included the weaknesses inherent to its retrospective cohort study design. The study was also performed at a single high-volume tertiary care center, which limits its generalizability. This study is strengthened by its matched cohort design to control for certain confounders. It was also adequately powered to detect differences in the incidence of perioperative adverse events, which were defined a priori. In conclusion, vaginal native tissue hysteropexy is associated with shorter operative time, less blood loss, and a lower odds of experiencing any perioperative adverse event compared to vaginal native tissue colpopexy with hysterectomy. In addition, the incidence of adverse events does not appear to differ between uterosacral and sacrospinous ligament hysteropexy. Thank you again for the opportunity to present our research.